Hi everybody and welcome back. My name is Mark. I'm the Principal Osteopath at ML Therapies and I'm also a lecturer at the Irish College of Osteopathic Medicine. Hi everyone, and in this video we're going to talk about the brachial plexus and some of the brachial plexus assessments. So in particular we're going to be talking about the dermatomes and the myotomes of the brachial plexus. So the brachial plexus consists of 5 nerves, which is C5, C6, C7, C8 and T1. So when we're assessing the dermatomes, what we're talking about is assessing the skin sensation or pain referral area from those nerve roots. And when we're talking about the myotome assessments, we're talking about the muscle actions that those nerve roots control, or those nerves arising from those nerve roots control. So the first thing we're going to show are the dermatome assessments with our model Rochelle. So in relation to our dermatomal assessments, what we're assessing are the dermatomal patterns of pain referral or change in sensation in the upper limb. So when we're assessing the patient, we can assess this bilaterally, and we ask the patient to place their hands out in this position, both sides, and our C5 assessment is this area here. So this is the area of our C5, our C6 is brachyradial down towards the thumb and some of the index finger. That's C6. C7 is middle finger, half of each, tracking up through the mid of the forearm, nearly up towards the elbow. C8 is the pinky and the underside of the ring finger, tracking up the under aspect of the forearm. C8 crosses from below the elbow up to the distal 2/3 of the tricep underarm area. And then T1, which is not part of the brachial, T1 is the upper part, but T2 is up at the very upper inside aspect of the axilla. So we have C5, C6, C7, C8, and T1. And again, T2 is not part of that complex, but can be assessed along with it. And if we were to turn Rochelle around, what we're talking about is this aspect back here for T1. So again, if we're assessing from this position, we have C5, C6, C7, C8 and T1 with T2, which is not part of the brachial complex behind. So one of the things that's also worth noting are what's called the ascending nerve pathways in relation to assessing our ascending nerve pathways for our dermatomal tests. So we have our lemniscal pathway and our spinothalamic pathway. So our lemniscal pathway basically means when we're assessing light, touch and heat, we can see it in the imagery here, that when we assess our light, touch and heat, they will present as diminished for peripheral nervous system issues on the same side of the lesion or problem, whereas the opposite is the same for our pinprick or sharp pain assessment on the dermatome. So our spinothalamic, which is the opposite side. So the way this works is, if you're testing this side of the patient, what we're assessing for light, touch and heat for the dermatome sensation, which is brush sensation and slight warmth, we're testing any dysfunction or lesion on the same side. When we're testing our spinothalamic, we come to the opposite side on the corresponding segment and we can pinprick that side, and that is on the opposite side to the lesion. So the way that works is the signal comes in, crosses over at that level. If there's an issue on the opposite side, it'll block and it'll be diminished on pain sensation. So just to regroup that again, the lemniscal pathway will always be diminished if it's positive on the same side of the lesion, and our sharp pain, which is our spinothalamic pathway, will be on the opposite side of the corresponding segment. So for example, if we're assessing C5 on the lateral deltoid, we would assess light, touch and heat on that same side of potential dysfunction. We would then test the opposite C5 on the lateral deltoid for pinprick, and we should have a corresponding diminished on both sides for those issues. I hope that helps. Thanks for watching. So in this video, we're just going to demonstrate the myotomes, or the muscle, the nerve innervation for the muscles from the brachial complex, working from C5 down to T1. So from here, we assess this bilaterally generally. We're just going to assess the left side for now. But if you're testing this with a patient, we would test it bilaterally in these respective positions. But for argument's sake, we're just going to demonstrate it on the one side. So for C5, we test lateral abduction. So the patient just has to resist as we push down through lateral abduction with the hand placed above the elbow for compression. Pain and reduced power is not an indication, merely just power loss, the arm will just collapse. So we have C5, then we have C6, which is bicep curl and wrist extension. So we can hold the wrist separately, the patient holds that wrist extension and we try and pull, so that's C6. C7 is the opposite, so it's tricep, so I push up, the patient then resists. Testing the distal aspect of that, the wrist curls and we try and hold. So that's C5, C6, C7, C8, you can cluster the wrist, the thumb can be extended and we try and push the thumb for C8. And we can also use ulnar deviation, so in pull from ulnar deviation for C8. And T1 is simply fingers open and fingers closed. So they can hold the fingers open and we try and squeeze. The practitioner will always overpower here, so be careful not to misinterpret that. And then we can actually clasp our fingers in through and ask them to squeeze or test each one respectively as needed. This is usually assessed bilaterally. When we're assessing the brachial complex, one of the other assessments we'd like to add into the mix would be our deep tendon reflexes. So within our brachial complex, we have 3 deep tendon reflexes. We have C5, C6, and C7. So we're going to demonstrate that on Rochelle. So C5 is the bicep, deep tendon bicep, brachyradial is C6, and tricep is C7. So we're just going to demonstrate that next. So when we're doing our bicep reflexes, generally we can leave the arm slightly elevated off the couch, place 2 fingers over the distal end of the bicep to where the tendon is placed and have a brisk strike, not a fast hard strike, it's a fast sharp short strike. And we just tap and we should have a jerk reflex in the forearm from the bicep pulling. So that's our bicep C5. C6 is on brachyradial, but again, this can be quite a tender area to strike. So again, I generally place my 2 fingers over the last 3/4 of the brachyradial area, just pre-styoid process of the radial and tap. And we should have a brisk enough reflex on the hand, the C5, C6, and C7. Place the arm across, slightly stretch out the tricep, and we have the tricep tendon here and strike. And we should have a little jerk reflex off the forearm if the hand is nice and relaxed or the forearm is nice and relaxed on the test. Being mindful that these can be sore from time to time, and if you miss, you can strike the elbow or some of the bony prominences and it can be quite painful. This is the reflex hammer that I like to use because it's long and you can change the length in it as required, and the bell is round so it's less likely to miss, and we get a nice whippy fulcrum that's required for the test.